Pulmonary function test. I know you guys have a bit of a flavor about the PFT in the 5th year, but it's time to dig deeper about the PFT and get comfortable with. هو من التست اللي very unique, and if you really understand it well, it may stick with you for a long time. It's very practice, very handy, and it's honestly one of the tests making a lot of sense when you understand the algorithm and the approaches. Okay, so those are the objectives. So why the test? Why the pulmonary function test is useful, and when we can use it? Well, one, we can use it for diagnosis, certain diagnosis in pulmonary disease. The PFT can be very helpful, and we'll come to that shortly. Also, it can assess the functional of impairment. It's a kind of where they are, and is this affecting their function, okay? The third is monitoring treatment. So, for example, if you have a certain disease, let's say asthma or fibrosis, you will give them an intervention. Subjectively, they may not feel an improvement, so we can actually monitor that objectively by the PFT, as well as capturing the progression of diseases. Okay. Okay. So this is one of the pulmonary function test rooms, and you always can ask the patient to know whether they actually did the PFT or not. Ask them if they've been in this glass box, okay? Because you need to have a control over the volume, okay? A lot of people, they will confuse البيك flow والأشياء اللي تسويها بالbedside or بالemergency to the full pulmonary function test, which usually happen inside a box. Okay. Okay. So volumes and capacity. I'm pretty sure you guys have that in the 5th year, but it's always good to remember it because it's very important in today's lecture. Okay. So when we breathe in and out without knowing that we are breathing, هذا نسميه tidal volume. المد والجزر. يعني we are naturally breathing without actually be aware of that. So this is actually just هذا اللي تشوفونه فوق تحت هذا. This is just the tidal volume. Okay. While if you expired all the air inside your lung, expired everything, you're still gonna have some gas inside your lung. This is what we call it residual volume. You cannot get it of the residual volume. It's always gonna be there. Okay. The functional residual capacity is basically when you are taking in and out with the tidal volume, خلينا نقول breath that you are not aware of. You can actually, right after expired some of the air, that's meaning you already have functional residual capacity. You weren't aware that they are actually exist. Okay. Another important one is the vital capacity. Okay. So it's basically a deep inspiration after a deep expiration. So when you expired everything inside your lung, and then you take a deep breath, that's what we call it a vital capacity. Okay. And then don't forget the total lung capacity is basically everything after a deep inspiration. So everything, including the vital capacity plus the residual volume. Okay. Inspiratory reserve volume. Remember, when you take the tidal volume, while you are not aware of, you always can push yourself to take a deep breath. Okay. That's meaning you have a reserve inspiratory volume. You haven't actually used it and utilize it, but you always can do that. Okay. I don't want to take too much time in this. You can review it in your own time, but this is very important to understand the terminology because we're going to talk about them like everyone familiar with them. Okay. Any question about those lungs volume? 1 minute. Okay, guys, واضح. Okay, good. Sorry for someone interrupting me. Okay. Okay, I like this slides because it explained a lot to me, and I always can imagine the exact volume by seeing this slides. Okay, so we'll take it one by one. Here in A, and the volume, this black is represents the normal individual. Okay, and you can see that in 1 second we already do an expiration breath. يعني most of the breath we expire it in the first second. You guys can see that. So this is all the volume. This is the time in the first second. Most of the expiration already been done. Okay, that in the volume. You can expire your breath for 5, 6 seconds, but most of it gonna be expired in the first second. Okay, compare that to people with obstructive lung disease. They will take time. So in the first second, they are not gonna expire all of their volume. Okay, in the restrictive lung disease, they don't expire a lot. You see this red. But most of what they expired, it's going to happen like a normal individual in the first second. Okay, so this is the first figure here. The second figure here is basically this is the flow, okay, and this is the volume. So you see the black again. Most of the first second is very important in the normal individual because most of the flow going to happen at that time. Okay, compare that to people with COPD. So you see this in red, sorry, in green. This is all going to be shifted to the left side. Okay, so the volume, all the volume is going to be actually up, and you see this scoop. Oh, okay. Give me 1 second. اوكي معليش يا عادل اللي متعبك معنا اليوم. Okay. Oh, okay. So back to this figure, you can see that in obstructive lung disease, all the volumes are actually up because the figure is being shifted to the left. So this is all volume. Compare that to the fibrosis, which is in red. You will see the volumes are all shrinking. It's like normal. The fibrosis is like normal, but all being shrinking and shifted to the right. Okay. Okay. So that's the breakdown for what's happened in obstructive and restrictive lung disease. Okay. And probably you should guys know that by now, but it's always good to go over them over and over. Okay. So in obstructive lung disease, the first expiratory volume over the vital capacity, okay, it's decrease, and that decrease is coming from what happened in the first second, because we already said in the first second it's going to be reduced. So if the top reduce, the ratio will be reduced. Okay, so FEV1, you will see a decrease in the first expiratory volume. The forced vital capacity can be decreased, can be normal, but the decrease wouldn't be significant, because if it is going to be significant, we'll see the ratio being normal, which doesn't happen with obstructive lung disease. Notice the total lung capacity. The total lung, what's inside the lung, it's usually actually normal or increase. Normal or increase, because the lung volume at total is actually up. There is a lot of, let's call it, trapping air inside the lung. And this is why also the residual volume, whether normal or most of the time, going to be actually increased. This is all in obstructive disorder. How about restrictive? Well, we said the FEV1 over the FVC gonna be normal or sometimes even increase, but to simplify things, it's gonna be normal. Why it's normal? Because both the first expiratory volume and the vital capacity both gonna be decreased equal. So that's meaning the ratio gonna be normal. The total lung capacity is actually shrinking, so it's gonna be decreased, and they don't have a lot of residual volume. Guys, time to ask questions. This is one of the most important slides in this lecture, along with the algorithm we're going to have shortly. Would you please repeat it? Okay. قد يكون بالمثال يتضح المقال. At least for now, remember what's in red. In obstructive lung disease, a ratio, the FEV1 over the vital capacity will be decreased. And the reason is the forced expiratory volume in the first second going to be a decrease. While in the restrictive disorder, the total lung capacity and the vital capacity and the residual volume, basically all the volumes going to be decreased. Okay, so again, I always like to jump into example just to get familiar with the PFT. You know, there is a lot of numbers and sometimes you get lost in those numbers. But if you know what you're looking for, I think you're going to be okay. Okay. So all of these numbers, what we're really going to be focusing on is the FEV1, the forced vital capacity, and the FEV1 in the first second over the FVC ratio. That's very important for us, as well as we'll go here to total lung capacity, residual volume, and we'll talk about a DLCO shortly. Okay. Okay, so a lot of information, but it's really can be distilled and can be focused for non-specialists to 5, maximum 5, 6 markers we are looking for. Of course, the others are important, but it's beyond the scope of this lecture, as well as it's really for a specialist. Okay. Okay. So this is the algorithm I was talking to you about. If you are not good with memory, try to remember this one, because really to remember it, you have to understand it. And once you understand it, you're going to master the pulmonary function test. Okay. So when you have a PFT results, the first things you should pay attention to is the ratio, the FEV1 over the vital capacity, or called forced vital capacity. Okay, that's the first things you would do. If the result is less than the lower limit of normal, less, so it's going to be no here. The question here, is it more? No. Okay, so you will focus here. Basically, we're talking about obstructive lung disease. Okay, yes, it can be mixed defect, but mostly going to be obstructive lung disease. Okay, so you're going to see the vital capacity. If the vital capacity is above the lower limit of normal, this is obstructive. And don't focus on a mix. I think it's beyond 6 years. I think maybe the medicine residents should know that, but not you guys. Okay. Once you establish there is an obstructive lung disease, you will see the DLCO. And let me explain what's DLCO. DLCO, or shortly DELCO, is basically to see the gas exchange at the alveolar level. Okay, so to see how freely the gas is exchanged from the alveolar to the capillary, okay? And you compare it to the normal, okay? Because a lot of lung disease will destruct this alveolar gas exchange, which gonna lead to low DLCO. For example, in emphysema. So in emphysema, you're gonna have a destruction of the alveoli. So when you check that DLCO, it's gonna be low, okay? Comparing to asthma and chronic bronchitis, they will be normal because those are a disease affecting the bronchioles and the bronchi more than the alveoli, okay? Okay, let's talk about the other. Let's say the ratio where actually, yes, it's normal. It's above the lower limit of normal, okay? So here, we're really talking about restrictive lung disease as well as pulmonary vascular disease, okay? So let's say the ratio are normal. You check the vital capacity, it is low. So that's meaning there is a restrictive lung disease. There is two major types of restrictive lung disease can be differentiated by the DLCO. Interstitial lung disease and pneumonitis, usually it's also gonna destruct the alveoli. So it's gonna cause the DLCO to be low. Compare that to people with chest wall abnormality or neuromuscular disorder. Those, the gas exchange gonna be normal. Yes, they will have a restrictive lung, a lung gonna be distorted, but the gas exchange gonna be normal, okay? Let's say the vital capacity were actually normal. We're talking about pulmonary vascular, for example, pulmonary hypertension. That's meaning the exchange actually gonna be higher than the normal individual, okay? And don't forget, we can have someone doing pulmonary function test and end up having a very normal pulmonary function test. Okay, time for question, guys. اسألوا قبل أن تسألوا. Okay, if you guys don't have any question, we'll move on to examples. Okay, okay. So المشكلة يعني بالغالب we need volunteering to go over this, but okay. So 21 years old, female with a shortness of breath during exercise. What the first things we should look for in this PFT? I need you guys to participate. It's a question. How about here? So what's the first things we should look for? Yes, good. Ratio. First things. So the ratio, the FEV1 over the FVC ratio here, the predicted is 81. She had 49. So did she have normal ratio? Reduce. A legal COPD, don't jump to conclusion yet. Let's learn the approach, okay? Okay, so we have it reduced. So most likely we are talking about an obstructive pattern, okay? So what's next? What should we see next after the ratio? I will go back here. Yalla. Okay, good. FVC, VC, good. Okay, so the VC here, the predicted is 4.8. She got measure 4.22, so it's 88 of the predicted. So is this normal? Very close to normal, isn't it? Yeah, very close to normal. Okay. How about, so let's go back here. How about TLC? Total lung capacity. Do you guys see it? So TLC, the first one here, predicted is 6.68 liter. She got 6.99. It's 105% of predicted. It's increase, yes. So this is actually toward obstruction, okay? Here, are you guys following? Hopefully, yes. Okay. After that, we're gonna see the DLCO. So what is the DLCO here? It would be somewhere here. Okay. So a measure is 3.1. Predicted 333. She had a 94% of predicted. Is this normal? Yes, it is normal. So what is the differential around normal? Yeah. So what is the differential diagnosis for her? So اللي COPD, unfortunately no. هذا هنا حنا. So whether asthma or chronic bronchitis. So her symptoms, is it going toward chronic bronchitis or asthma? But the ratio is very low. The ratio of what? A ratio of FEV1 over FVC? It's low in both, in asthma and in chronic bronchitis. Okay, so let's try to wrap up this case. So we have a reduced ratio. So this is obstructive pattern. We have reduced FEV1. A total lung capacity was above or equal to lower limit of normal. So this is pure obstruction. We have normal DLCO. So this is so far asthma or chronic bronchitis. Okay, so here my question, guys. You guys see here in the FEV1, there is something called pre and post. Anyone have any clue what's pre and post mean? What's post BD mean? What's BD mean? واحد يقول after BD. Okay. Yes, after bronchodilators, absolutely. So those individuals, after finishing the initial test, we'll give them bronchodilator like Ventolin to see their response, okay? And we pay attention to the FEV1 response, that's one. So you see here pre, it was 53, post, it was 58. So not far away from each other, okay? But look at the FVC, a vital capacity. It was 88, and now it's 112. So this is a significant improvements after the bronchodilators. And this is one of the indications this is actually reversible airway obstruction, likely asthma. Okay? So the significant bronchodilator response differentiates between the asthma and the chronic bronchitis. BD is bronchodilators, yes, yes. Is the case clear, guys? Okay, let's take another example. But I really like you guys to يعني ratio still worsening even after. Yes, it can happen. The ratio, it can happen in worsening. And the reason, don't forget FEV1 over the FVC. So not all should be responding to the bronchodilators. What we are looking for is basically a 12% increase and absolute improvement, at least 200 ml after inhaling beta agonist, whether in FEV1 or FVC. واحدة منها. So bronchodilators, we don't look for the ratio. We focus على FEV1 by itself or FVC. If any of them have a significant response, we'll call it a positive bronchodilators response. Okay. Second question, guys. I need more participation in this. 62-year-old female with progressive dyspnea. First things we see. أول شيء نشوفه. Ratio. So what's the ratio here? We see FEV1 over FVC. A ratio is 101. Is it normal or abnormal? Okay, so it's normal. Okay, so this is unlikely to be obstructive. Maybe it's normal, maybe it's restrictive. Okay, so what's next? Okay, we'll go back. What's next, guys? VC, vital capacity. Okay, so what's the vital capacity here? It's 56% of predicted. So this is really restrictive, isn't it? Reduce, yes, which goes with restrictive lung disease. حتى TLC, 72% of predicted. Okay, so what's next? So we found out that a ratio is normal. She have reduced vital capacity, reduce TLC. What's next? Okay, DLCO. So her DLCO is 30% of predicted. So it's reduced also. So what's the conclusion? So we have someone with a normal ratio, reduce vital capacity and total lung capacity, and DLCO. What's the conclusion, guys? ILD or pneumonitis, absolutely right. So the ratio was normal, so above the limit, lower limit of normal. The VC was low. The TLC was low, restrictive. We did the DELCO. The DELCO was low, so it's really interstitial lung disease or pneumonitis. Okay? Okay. Okay. Next. 55, heavy smoker with dyspnea. First things we look at, guys. Chop, chop. Should be very fast, this one. Ratio. Okay, so ratio here is 45% of predicted. Is this normal? %. Is it normal, the ratio? Come on, guys. Okay, so it's decrease. أحسنتم. Next, we see what? VC. Okay. اللي يسأل عن ال VC, it was 90%. It was 2.9. So it's normal. Look at the TLC. ايش رايكم ب 117? Is this normal? No. Yeah, it is actually significant. That's meaning there is a lot of air inside the lung. What's next? So we know that there is an obstructive pattern now. Okay? So how to differentiate between asthma and chronic bronchitis versus emphysema? DLCO. Okay. Whoever asked for the DLCO, it's 50%, 52% of predicted. Is this low? It is low. So what's the conclusion? I will go back. So, and the ratio was low. So we are talking about here. A vital capacity, yes, it was normal, but the TLC was above the lower limit of normal. So we are talking about obstructive. And then we did the DLCO was low. So we're talking about emphysema. Okay. So, sorry. Reduce the ratio, it's obstructive pattern. Reduce FEV1. TLC above or equal lower limit of normal. So this is pure obstruction. We have a reduced DLCO. So this is compatible with emphysema. Okay. لاحظوا about the bronchodilators, I put a note that FVC, the FVC here, what is the FVC? Yeah. So yes, لاحظ 2.9, it's become 3.1. And this can happen just by the way the patient sometimes is breathing more than the bronchodilators as a response. Okay. Okay, how about this? 47-year-old sudden onset dyspnea. First things to look at, guys. Come on, ratio. Okay, ratio is I predicted 75. She had 73. Is this normal? Normal ratio, okay. And see, the lower limit of normal was 65, so she's 73. So normal. Okay, next. Around, yeah. Next. VC. Okay, you ask for a VC. It's actually 4.8 as predicted. She had 4. She is 82% of predicted. But she is above the lower limit of normal. So she's around. She's okay. So what's next? قبل الدلكو, let's see her TLC, huh? Total lung capacity. Total lung capacity, she's having 108%. So it's above normal. So remember the following, huh? We'll go back here so we can put it as our guide. A ratio was here because it was normal. The VC was actually above a lower limit of normal, so she is here. DLCO. When at DLCO? DLCO, I predicted 26, she had 20. So it was 77% of predicted. Someone asked, بس احنا قلنا ان البي سي اكبر. البي سي here, the lower limit of normal was 3.89, okay? And she got 4. فخلنا نرجع. So yes, she is actually above a lower limit of normal. معانا يا عبد الرحمن؟ So we are here. Okay. DLCO, guys. So basically, DLCO is not bad when you correct it. So it's 89%. So really, in this individual, we're going to look for other causes, in particular, anemia or PE. And it seemed to be that probably here, when you correct for the DLCO, it becomes 89. That's meaning there is a factor like anemia contributing to the low LCO. Okay, and look at the hemoglobin, it's 10. So she already actually anemic. Okay, question, guys, about any of the 3 lectures. الله يعافيكم. Is this working, guys? Let me ask you, لأنه those lectures I used to present it actually in the lecture hall. Yeah. Yeah, look at اللي يسأل عن ال DLCO, look at the corrected DLCO. It's 89%. So هذا DLCO ال 77, it's not corrected, but the corrected one is 89%. And they corrected for a lot of factors. The most important one is the hemoglobin. طيب متى أقول إنها أكبر وأصغر؟ Well, if you have the lower limit of normal, that's the best one to use. If not, you have to use your common sense. Okay. Is this lectures working? يعني do you guys find it useful, or shall we change our style completely?
دكتور السلام عليكم.
عليكم السلام ورحمة الله.
بس في سؤال بالنسبه للدي ال سي او، اللي ما فهمت انه ليش احنا اذا كان عندنا ال ان اللي هو اللور نورمال، ليش نطالع بالكوركتد 1؟ مو خاص نقول
Yeah, when you have the corrected one, actually use it لأنه it's corrected for other factors, and those factors are important لأنه it doesn't have anything to do مع lung. It's usually have something else to do, in particular مع خلينا نقول body weight as well as with the hemoglobin level. So when you have a corrected one, use it.
طيب الان زي كذا مثلا كان ال 77 اللي هو البريد، بعدين صار 89، هذا اعتبره ايش؟ اعتبره يصير اقول انه اكبر من اللور ولا اصغر؟ يعني لما نرجع للجدول الاساسي اللي قبل. اي
شوف هنا نفس هذا I'm still sharing the screen صح؟
ايوه تمام.
شوف الكوركتد دي ال سي او اللور ليميت اوف نورمال is 17.4 صح؟
تمام.
وهي she made 20.3 so she's above the lower limit of normal.
ايوه تمام حلو.
But be mindful guys, different machines will give you different results. So not all the machine will have a corrected DLCO. Not all the machine will have a lower limit of normal. Sometimes they will give range. Okay.
يعطيك العافية، وضحت، شكرا لك.
Any other question, guys? Is this useful? يعني ترى اليوم المشكلة حد المحاضرات يعني arterial blood gas وال PFT. It's really you're gonna learn it by doing example more than the lecture itself. فارجعوا شوفوا إذا كان عندكم cases من سنة خامس. Find online and email me if you have any challenge case. We can always go over them. يعني we usually gonna finish a good 15 minutes early sometimes, so we always can do more exercise. Okay. الله يعطيكم العافية جميعا. زي ما قلت لكم